The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and good morning to you if you're on the West Coast. My name is Jose Leon, Chief Medical Officer at the National Center for Health in Public Housing. I want to welcome and thank you all for attending today's webinar, The Impact of Electronic Health Record Use on Health Center Staffing and Productivity. This webinar is being recorded, and the resources, the slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, there will be a question and answer session. Please do not forget to respond to our post-webinar survey. Your feedback is very important to us. I would like to thank HRSA for allowing us to make this webinar possible. The National Center for Health in Public Housing is a national cooperative agreement funded by HRSA to provide training and technical assistance to health centers located in or immediately accessible to public housing. Before we get started, I just want to share some information with you. This is the most recent UDS data in regards to electronic health records. And as you can see on this slide, most or almost all of the health centers have EHR established. This is the latest numbers, and most of them have installed electronic health records at all sites, and some of them, only 47, have installed electronic health records installed at some sites. There are other health centers that will install the electronic health records in the next 3 months, and then there is only 3 that will install the electronic health record system in the next 6 months. Then there are only 4 health centers who responded that they are not planning on installing the EHR system. So this is very important because right now we are going to review a study that GW did for HRSA, and this is on perceptions of electronic health records effects on staffing, workflow, and productivity in community health centers. So we are going to discuss the findings of the GW report. We are going to review the effects of electronic health records on staffing and productivity in community health centers. And we are going to summarize the benefits of electronic health records and their effects on staffing and productivity. So I would like to get started and introduce our speakers for today's webinar. Our first speaker is Dr. Maslink. She is an assistant professor in the Department of Health and Policy Management. Before coming to George Washington University, she earned a PhD in Health Policy and Management from the UNC Gillen School of Global Public Health and completed a postdoctoral fellowship at UNC School of Nursing. Her work at UNC included studies of the role of nursing schools and other organizations in nurse migration in the Philippines and a survey of internationally educated nurses in the United States. Dr. Maslink has served as a consultant on projects focusing on health worker engagement, productivity, and performance management with the Health Workforce Development Team for the USAID Healthcare Improvement Project. Her current projects focus on the effects of health systems transformation on healthcare organization and the healthcare workforce, innovative uses of health workers, and cultural change in healthcare organizations. I'm turning the presentation over to Leah. Good afternoon, Leah.
Thank you so much. Okay, does that look good for everyone?
It looks good.
Excellent. Thank you so much. So like Dr. Leon mentioned, I am an assistant professor in the Department of Health Policy and Management at the Milken Institute School of Public Health at George Washington University. And this was actually a qualitative exploratory study. So we actually spoke to a number of health center staff members about their experiences with electronic health record implementation specifically as it related to staffing, workflow, and productivity, although we heard about a lot of other topics too, as I'll describe. And this was part of our HRSA Health Workforce Research Center Cooperative Agreement. So a little bit of background. This is probably not new information. In fact, it's been highlighted already. The number of community health centers that are using EHRs has actually more than doubled since 2009. A lot of this activity has happened because of federal investments under the Health Information Technology for Economic and Clinical Health Act, or the HITECH Act, and the Affordable Care Act. EHR implementation has been looked at a little bit in relation to staff roles and staff models, and linked to some new and changing staff roles in primary care. The addition of new roles like scribes, people who enter information into the EHR, IT staff that need to manage the EHR, and quality improvement staff that can really take advantage of it for using the data for quality improvement. It's also been known to change the roles of existing staff members like medical assistants and nurses. EHRs are also known to cause significant changes to clinicians' time use and productivity. There's been a number of studies in this area that have found that clinicians spend more time on certain tasks, so things like charting and preventive care, and less time on certain other tasks. In this particular study, prescribing and within office communication, because some of that information may be contained in the EHR. So EHR implementation by community health centers enables us to study how the new technology intersects with staffing changes to influence care delivery. CHCs are known to be flexible in their staffing and use a lot of innovative approaches, but you're also, as any of you who are from health centers well know, subject to a lot of data reporting requirements, incentives, et cetera, that may cause some different types of changes that we might not expect to staffing decisions, workflow, productivity. So the objectives of this study were really two, very related. So trying to understand health centers' implementation of health records, how it changed staffing models, staff roles, and workflows, so sort of who works in the health center and what they do and how they work together, as well as understanding mechanisms by which using EHRs could influence productivity, coordination, and quality. So like I mentioned, this is a qualitative exploratory study. So we conducted interviews, semi-structured interviews with 17 staff members that worked at different health centers. So we aimed for health centers that had a variety of staffing configurations, different levels of experience with EHRs, figuring that we would try to maximize the variety in our sample so that if we saw things, we could be really confident that this were sort of an accurate representation of what's going on across the field. The domains are like what I mentioned, so a lot around staffing, but we're also interested in productivity and coordination. And like I mentioned, this was funded by our HRSA Health Workforce Research Center Cooperative Agreement. So we actually, to try to figure out which health centers might be possible candidates to participate, we used the 2014 UDS. We actually conducted a study a couple of years ago. So it was the most current data that we had at the time, and that we used that data then to try to aim for a variety of CHC size, look for CHCs in different states, knowing that that can have an influence as well as state policy context, experience level, and also even try to find ones that were on different EHR systems, knowing that the actual vendor that you work with can also be influential. So we conducted phone interviews with administrators, support staff, clinicians, across those 6 CHCs, and then we audio recorded and transcribed them and conducted our thematic analysis in a program called Atlas TI, which is a qualitative analysis software. So the way I'm going to present the findings is actually going to be mostly with quotes. These are kind of big themes that we found, and then I'll talk about how each quote illustrates it. So we did find that EHRs were useful and were influencing the addition of new staff in some cases. This is an example where a health center, so the Medicare wellness visit is like a visit that needs to be conducted when each new Medicare patient joins or goes on to Medicare. And this was a scenario where they thought they were getting it done, and they realized using EHR data that they were not. And so actually were able to hire a nurse practitioner to meet that need using EHR data. That might have not been a need that they would have even seen otherwise, and that'll be kind of a theme that we'll see again. So this was an interesting discussion that we had with a nurse about the role of enabling staff members, so people like case managers and community health workers, et cetera. The fact that sometimes it's actually hard to document their contributions, even using some of this EHR data. This was somebody who really wished, actually, that she knew how much this person was accomplishing and actually wished the EHR would have been a little more useful in showing how much, how much work this person was doing and how much they were contributing. But sometimes even realizing some of the limitations of the reporting from the EHR, that was often not as easy as she hoped it would be. So in the context of expanded staff roles, so thinking about, what might existing staff members like medical assistants or nurses, what might they be able to do now that they wouldn't be able to do before because of the EHR, because they could use standing orders and other tools to kind of maximize those roles. I think a lot of these health centers recognize that and were looking to do that. I think they were also, this is a nurse who's describing that it is, there's not necessarily one right way to do it, and they still felt like they were still kind of wrestling with that. So who's going to be the one to ask the questions and to kind of tee up the patients for the doctors? Should that be a nurse? Should that be a medical assistant? How do we partner them with providers, et cetera? I think that they saw the potential, but also felt like there was still some unrealized potential with maximizing the value of some of those people and just making their work more fulfilling for them as well. So an interesting discussion that we had with a few health centers was around using EHRs to foster provider trust in some of these staff members, so people like medical assistants. So convincing, as this person says, trying to help the provider realize it doesn't need to be a one-person show. That and actually finding in this case, they found it actually was very helpful because all of that documentation then enabled the clinician, the provider, to go back and see what had been done, ask any questions, know that things have happened the way that they hoped they would, and so actually let them let go a little bit and entrust more of those tasks to the medical assistant. When we talked about expanded staff roles with some of our participants, they also talked about the fact that making these roles more complex and more, having more tasks and probably more decisions meant that sometimes they also had to look for people with a few different qualities that they maybe than they would have before. It's not just about someone with a particular license or certification, but really how do they deal with uncertainty, what kind of critical thinking skills do they have? And then once we've identified those people, where can we find them as we need them to fill our staff? And or how do we work with if some of these places may be in more areas where they're sourcing from a certain pool of schools. Maybe we need to go back to the schools and actually talk to them about how can we elevate the critical thinking of the people that you're putting out into these medical assistant or LPN type roles to make sure that they can really fill the job as it exists now using some of the EHR tools, et cetera. So the health center, I think a lot of our participants, again, especially a couple of years ago when this was really new for some people, did definitely find that the EHR, they felt like it had a lot of potential for helping them track patients in a way that they really couldn't, kind of take responsibility not only for patients that show up at the health center, but also maybe for those that don't. So this is a COO who was talking about a provider who, until they saw the data, didn't realize that they probably had certain patients that they forgot about entirely, who had diabetes, and they really should be seeing them on a regular basis. And so having the EHR data, be able to pull that and look at it and know these are people who haven't been in for a screening, these are people who should, that we should contact to invite them to do that. They found that very helpful. I think there was a lot of feeling that there was some unrealized potential here as well, that they were sort of only beginning to understand the ways that they could use the information and interpret it, or even sometimes even having the personnel to work on the quality improvement. I think Sonia is going to talk more about that in the next presentation, but just how do we really maximize the deluge of information that we're getting about our patients. So we did ask about productivity, and I think it's always a little bit difficult to define productivity. I think most of our participants did tend to think about it in kind of a throughput, how many visits kind of way. And across the board, they said, if you think about productivity that way, we are never going to get, the EHR isn't helpful in that way. It sets us back. And even definitely in any kind of period of transition, so both in adding, starting with an EHR in the first place, and also around updates. Some of them found that very burdensome. Some of them had done a lot of customizations that then would sometimes be lost in ways that they might not even realize until later. So then it would be a lot of burden both on providers and on any quality improvement staff or IT staff trying to kind of get things back where they were. But I think across the board they said, the visits probably are always going to take a little bit longer. This person also does say that she thinks quality has increased in the sense of, being able to track patients outside, knowing who needs to be in for screenings, et cetera, et cetera. But in the actual sense of just being able to move volume through, they all saw it having a negative and pretty long-lasting impact on that type of productivity. On the other hand, they definitely saw that using all the data, having all that data available to them, was helpful for coordination within the facilities, particularly. Some of these health centers were large health centers that even had multiple sites. So even across the multiple sites, it could be useful in this context of, knowing that if someone says that they're going to do it, that they've done it, being able to check and know, has that prescription been sent, has that call been made, et cetera. Knowing that all that information was right there was really, really helpful. And they definitely felt like that made certain parts of certain people's jobs easier. On the other hand, we asked about sharing information between facilities, so with other providers, and this is still, I'm sure some of you who are in the field know this, a mess. It's really, really difficult. Even if one site has implemented EHR tools, they often are still receiving results by fax. They talked about having to do manual entry of certain types of information that maybe had been from before the EHR implementation or from certain other sites. Even some of the more sophisticated ways that they would share information still involved one provider would get an email, and then they would have to log into another site, and then they could see something from another provider. Even in some of these states, we talked to at least a couple sites that were in Maryland, which actually has tried to do some pretty sophisticated health information exchanges, and even so, there's still a lot of room for growth, I think, there, and definitely something that was burdensome rather than helpful. Even if ultimately the information could be shared. So this was another huge topic that we didn't really have it in our guide because we didn't realize how important it was to everyone, but we started asking about it as we started hearing about it. This idea that the EHR data, so it's obviously used for billing and it's used for coordination of care within the facility and sharing with other providers. It's also used for a lot of other purposes in health centers as well as for other providers. And so that raises lots of questions about where should that information live? Where does it, if some of these things like documenting smoking cessation, if you don't put it in the right box, I'm sure some of you know this who've had to do this, once we run a report, it will look like we never did it because we documented it somewhere else, and you can't write it in the text field. You have to check out the certain box, and a lot of effort around sort of trying to customize and make it easy for people. Also just a lot of burden on providers and other staff members of trying to make sure that all of this was put in the right place, and it wasn't really even about trying to tell anyone that they were working with directly information that would be easy for them to see, but it was really about this reporting. So for UBS, and then on my next slide, I'm going to talk a little bit about meaningful use, which was another topic that we talked a lot about. This is another, as the director of clinical operations, and this is the discussion. Remember, you have to put it right there. If you don't put it right there, it's problematic. And so the providers, may or may not have bought into the importance of this. And so sometimes they just want to see the patient. They get them what they need and go to the next patient. And then there's the possibility that they might not meet certain meaningful use requirements. So just a lot of effort and time and sometimes kind of reworking of things every time they had to do an update to make sure that all that information, to make it easy for providers or other people to put information in the place where it needed to go so that it was useful for communication as well as all of these reporting requirements. And they said, and we've heard this even in other studies that we've done, that there's only so much that people can keep in their heads at a time as well. And so there's only so much that we're asking our physicians to do. As the CMO told us, you have to be a little selective about what you push. Maybe we choose a few things and work on them a lot rather than trying to go after every meaningful use indicator at the same time. And we've heard this in other contexts too, that it's hard to, I worked on another study that looked at accountable care models in health centers, and it was the very same kind of thing of people can only focus on so many things at the same time. So especially wanting to make sure that those providers are happy, that they feel fulfilled, that they know what they're supposed to do every day. Maybe we need to be a little bit more selective about what we push every year, even if it means that we're making some trade-offs in some of those meaningful use in practice. So a couple quick limitations, and then I'll tell you some of the high-level conclusions. So one was that, of course, we use the UDS data to identify our participants, and that the data by this point are a few years old. So anybody who's just adopted, we haven't been able to include their story in our study. For now, if we wanted to go back, we could definitely add that. Most of the CHCs, just in our recruitment, the ones who tended to be more responsive tended to be the larger ones. So there may be some things that we learned that were more generalizable to larger health centers rather than smaller health centers. And some of the people, as things go in this field, in any field, some of them had only come to the CHC after the EHR implementation, so they didn't always have a full perspective on the whole story of what had happened from the very beginning. We also talked to people who'd been at their health centers for decades and decades and have seen lots and lots of change. So I think there was some variability, but I think we did get some pretty detailed stories, and a lot of these people had experience at other sites, even if they hadn't been at the same site the entire time. So a couple quick conclusions as I wrap up. So CHCs are finding creative ways to adapt staff roles and models, using EHRs to improve coordination and quality of care. One thing that I didn't mention before that was something that we heard was that we asked about scribes, knowing that that's something that in certain areas is a hot topic. Very little interest in scribes, at least in those populations. One site was using them in family medicine only, not even pediatrics. They didn't see the business case for it in pediatrics, but they did use it in family medicine. But across the board, otherwise, the providers really prefer to do their own documentation. And a lot of their, any adjustments to models that they did make were kind of built around that assumption. Some of the staff roles, like I mentioned, are trying to take advantages of some of these new functions to either reduce provider burden, so sometimes, offloading some of those tasks to medical assistants or LPNs, or to improve population health and quality tracking, so adding new quality improvement staff. Sometimes we need roles to manage new challenges, so new IT staff just to manage it. Sometimes they would do more of that on an outsourcing basis with some of these companies that will do that. But then, in any case, often had to have at least a point person or a super user committee of staff to make that happen. So as I mentioned, too, the influence of EHRs on decisions around enabling staff may be less direct because of that work is a little bit less documentable in the EHR, as one person mentioned, although they definitely, for some of these other tasks could really find that type of staff member very useful in coordinating and kind of having them maybe at the center of all of that movement of information about patients. So EHRs, as we found too, can be useful in fostering team-based approaches to care by enabling delegation, and that some of that's by fostering trust of providers in the people to whom they're delegating, knowing that they can communicate easily, that there's accountability, that they can check later and see what's been done. They've definitely been helpful in improving quality and population health, tracking patients, knowing who needs to come in who hasn't been seen for a while, et cetera. I think our sense is that there's a lot of unrealized potential there, that there's still a lot of room to grow and room to learn more, and sometimes that's a matter of staffing as well. Certain health centers, they just don't have people who are comfortable running reports themselves, so they end up outsourcing those tasks, and it becomes a little bit more burdensome. But I think there's a lot of interest, definitely. Interoperability challenges are still huge. Lots of add-on manual solutions, fax machines, et cetera, are still, all that's still alive and well. And in terms of communicating between providers, it's still just really, really challenging. And then this whole issue around where should the information live, knowing that we're using it for all these different purposes, including communication between providers, but also this required reporting, which for health centers is so important and tied to certain financial incentives, et cetera. But it can be also really burdensome for providers and staff. So I want to quickly acknowledge again our funder, HRSA, through the Health Workforce Research Center, as well as my collaborator. I did qualitative research you never do on your own, and so I worked closely with Lisa Erickson at the Health Workforce Institute. But she and I were both on most of the calls, worked did them together, and then worked with the data afterwards. So I really appreciated all of her work. And I'll see you. So thank you so much, and I look forward to the discussion.
Thank you, Leah, for this great, thorough presentation. And we are going to hear now from one of the public housing primary care grantees, La Maestra Community Health Center. We have two speakers who are going to present their experience with electronic health records and some of the challenges and what they have done to improve all the challenges and obstacles that they have faced throughout the EHR implementation. First, this is a joint presentation. We are going to hear from Dr. Sonia Tucker, and then from Sal Saldivar is going to join us in case you have any questions for Sonia that is more IT related. Sonia Tucker is a foreign-trained medical doctor. Sonia's first job was with underserved indigenous communities in Venezuela, where she learned to practice the importance of population health management, preventive care, and providing high-quality care with limited resources. Living in the United States, Dr. Tucker has had the opportunity to travel with different medical organizations that work in underserved communities in North America, Central America, and the Caribbean. Sonia joined the team at La Maestra Community Health Centers 4 years ago, and now is the Chief Quality Improvement Officer. In her role, Dr. Tucker and her team have focused on addressing all aspects of health and quality improvement, including analyzing social determinants of health data and developing action plans to integrate services and address underserved population barriers to care. Then we are going, in case it's necessary, we are going to hear from Sal Saldivar. He serves as the Chief Information Officer at La Maestra Community Health Centers and has proudly served there since 2013. In his organization, he's responsible for the state-of-the-art data center, network voice, and security infrastructure. At La Maestra Community Health Centers, Sal's technology focuses on business intelligence and population analytics, all based on their electronic health record system. Sal has been involved in numerous healthcare system design and implementations, providing direct benefit to patient care and increased revenue to La Maestra. Sal served honorably in the United States Navy. He obtained a Bachelor of Science degree, summa cum laude, in Health Administration Information Systems from California State University, Northridge. He has over 18 years of IT industry experience. Prior to joining La Maestra Community Health Centers, Sal worked as a freelance computer network consultant and then worked for DR Systems as a field service engineer. Sal also proudly serves as a top tech judge for the San Diego County. Now I'm turning the presentation over to Sonia. Good morning, Sonia.
Good morning, Dr. Leon. Thank you so much. Can you guys see my screen?
No yet. Let me make you the presenter, Sonia. And for a reason, I don't see you.
I can see it.
Oh, now I can see it. Yes.
Okay, perfect. Thank you. Okay, thank you so much, Doctor, for the presentation. And I have to disclose, I am going to do most of the talking, but I think I have to be honest, Sal helped me a lot on this because the IT part is his forte and not mine. And of course, a lot of what we're going to hear is going to be a lot about quality and how we have been able to leverage technology and EHR to be able to help the performance of our providers. Before I start, I want to introduce La Maestra and who we are and what we do. Our mission is to provide quality healthcare and education, improve the overall well-being of the family, bringing the underserved, ethnically diverse communities into the mainstream of society through caring, effective, culturally and linguistically competent manner, respecting the dignity of our patients. For me, it's very important that we understand our missions, because using EHR, we have been able to really stick to this particular mission, especially when we talk about culturally and linguistically competent. Collecting social determinants of health and acting on that has enabled La Maestra to stick to our mission. And we're going to see as we speak what we're going to be doing, what have we done to be able to accomplish this. We started in 1990 as an amnesty center, and little by little we have become not an amnesty center anymore, of course. We are a healthcare provider facility, and this is who we are. We have 7 medical clinics, 10 dental sites. I believe it's 11 now, and I know my director of dental operations is on the line, and I know he's going to say, Sonia, it's 11. 4 school-based clinics, 1 Hope clinic, which is a point for access for homeless populations. And in San Diego, we are located in San Diego County. The areas where we are is City Heights, El Cajon, National City, and Lemon Grove. We provide mental health services on-site and via telemedicine. We also have a state-of-the-art imaging center, and we have 2 mobile clinics that we are very proud of. One is a fully mobile dental clinic, and the other one is a 3D tomosynthesis mobile coach, which was the first in San Diego. We're very proud of that because our executives have worked very, very hard to be able to provide this for our population, our underserved population.
Sonia.
So, go ahead.
I was going to remind you to move your slides. Sorry.
Yes. So what I want to just make sure is this particular slide was given to me, or was a conversation that I had with Sal, or CIO, and this is how we look at the evolution of the EHR. It's important that we understand that patient medical records are more accessible than ever before, with data and technology becoming increasingly portable and comprehensive. It is important for us to know that we're not yet at the end of the technology and the EHR. We're still, Sal was saying in our conversation, he was saying, I think we are right now at the first generation smartphone in the EHR system, meaning that we still have a long ways to go, but nonetheless, the best is yet to come. So I found these slides and I thought this is perfect what defines our EHR, or the evolution of the EHR. It is important that we understand that we see where we came from and where we are right now, so that we are able to embrace technology. Our medical records went from this, which was a bunch of papers in a big area that occupied areas that we're now using for healthcare or for patient care, went to this part right here. So some providers are comfortable using technology, other ones not so much. But it is important that we understand that the EHR incorporates patient information into a system that gives providers greater accessibility and flexibility and functionality. And this has helped us to reduce the redundancy of care and lab work that we order to our patients, because we have the information right there at a click in our fingertips. And it's funny when I say clicks, because I know our providers, they usually said, oh my gosh, this is one more click. But it's important that we remember that before we would have to look through different pages to make sure that this information that we were going to order on the patient wasn't ordered before. So La Maestra implemented EHR, or adopted EHR in summer of 2012. It was before my time at La Maestra. And the EHR that we use, I have to disclose, is Next Gen Healthcare. We like what we do. Our IT department and our EHR department have been able to work with the vendor, and we have become quite versed in the EHR that we use to be able to customize different areas of our EHR to our benefit. So this is basically how our EHR looks like. This is our PM side where we collect the information when the patient makes the appointment. And this is very important for us because this is where we collect our social determinants of health. And this is our EHR side, which is basically where the care team is going to be documenting all the information that we're eventually going to be used to manage our patient's care. So what is important for us to remember is that the EHR, when it's properly implemented, is provide a more effective means of communication among the members of the care team. And it's important because the care teams have increasingly get bigger, and there is more people that gets involved in the care of our patients. So we have MAs, nurses, scribes, PSR, which is our front desk personnel. We have LVNs, providers, health educators, and everybody having access to this particular information will allow us to provide a better care and better outcomes for our patients. So now, what have we been able to, or in general, what the EHR has allowed us to do? First of all, it has allowed us to a stratification of our patients, the risk of our patients. How we have been able to do this, or how can any organization do this? The way that they can do it is developing a risk score by examining large cohorts or small cohort of patients, whichever is for you guys, what you guys want to choose, with similar characteristics, and extract the key clinical and lifestyle. Very important that we still remember social determinants of health. We should be able to leverage technology to access the social determinants of health, and using algorithms that can be input into your EHR to better influence the outcomes of the patient. Second, care team coordination approach. As a provider, I love that we are able to take care of our patients in a manner, in a care team, because as a former provider myself, I couldn't see myself doing everything all by myself. It was very important for us to be able to use everybody in the healthcare industry that we have, so the MAs, the RNs, and that helps them also to perform to the best of their licenses, so that we are empowering our employees to also do what they're passionate about to do. Development of more efficient workflow. I think we have come a long ways since the EHR was invented and implemented. The EHR has allowed us to be able to implement workflows that work for our health industry, specifically for La Maestra. It depends on who are we dealing with. And also the EHR vendors have been able to realize that we need some flexibility in order for us to be able to have workflows that are customizable for each need. Allowing patient engagement. I love this because when we educate our patients about the possibility of them being in charge of their care, where they are able to use a patient portal to communicate with their care team, where they're able to view the results, and also they're able to get education that they may not have been able to get at the time that they saw the doctor because they didn't think about the different questions. I love the fact that EHR has allowed us to be able to give that possibility to our patients. Coordination of care. This also entails part of the care team, but more importantly, this entails when we refer our patients out. Having EHRs have allowed us to be able to refer our patients in a more systematic manner, and has allowed us to also coordinate and communicate with other healthcare providers. Tracking of our quality outcomes. Of course, I'm biased on this because I am the Chief Quality Officer. So I remember before EHRs, it was very difficult to see how our patients in general, as a population health management, we were doing. We were able to see how one patient was doing, and it will take us a while to do that. And I think Leah mentioned in her presentation that there was somebody, a CMO in the past, that thought that he was that in the past before EHR that he was able to see, or that he thought that he was treating his patients right, that he was seeing his patients enough. To his surprise, when he was able to use EHR to run those reports, it wasn't what he thought. Now we have more accurate data that will allow us to give more quality care to our patients. It's the implementation of best practices. We as providers in general have the knowledge of best practices, but when we have to see patients and we have to move from one patient to another one, there easily things can be slipped through the cracks. So implementation of EHR has allowed us to be able to give that help to the providers where, you know, the best practices are right there into their EHR just as a click away. The collection and utilization of social determinants of health. It is important for us to remember that social determinants of health, it will determine or will help determine what is the outcome of that particular patient's treatment. If we are able to leverage technology in the utilization of EHR to collect and address social determinants of health, I have the hope that the outcomes of the patients will be much greater. And in general, what we at La Maestra call this population health management. And of course, once again, I'm biased because this is exactly what I do. Now, I'm going to give 3 examples of what La Maestra has done with EHRs. This right here that you guys are seeing is our circle of care, which is a model of care. It's a holistic approach of care to be able to serve our patients the best way we can. So one example is access to care. As you can see, being able to provide that particular access to care to our patients. In 2017, we have been increasingly seeing more patients from 2014, 2015, 2016. In 2017, we saw 47,866 unique lives. Most importantly, we were able to identify that 60% of those patients were better served in a language different than English. If we wouldn't have EHR, we wouldn't be able to do that. Now, what do we do with this information? What we decided to do was to make sure that we put some work on empanelment. We empanel the patients to the proper provider according to the language that they were served on or what information we had on demographics of that particular patient. If the patient spoke Spanish, we empaneled that particular patient to a provider that was able to serve the patient in their native language and that would understand their culture. And you know, if the patient spoke Arabic, we'll do the same. By the way, La Maestra's patients speak 28 different languages. Let me correct myself, not La Maestra's patients. We have 28 different languages being able to translate at our facilities at any given moment. Our patients speak about 52 different languages and dialects, and they come from 62 different countries. So for us to be able to leverage technology was a huge advantage to increase access to care and comprehensive care for our patients. Now, a lot of people have seen that these, population demographics, but what I think is important for us to remember and to mention is that population demographics goes alongside and hand in hand with social determinants of health. So with this being said, it is important that we notice that the EHR has allowed us to look at the population demographic down to the patient's level. How can we even say that we have 3.8% of patients that were qualified as homeless? Exactly a number, 1,866 homeless patients. We're able to also see if the patients were insured, uninsured, and even what kind of insurance they have. With this, we have been able to make proper referrals, not only for healthcare, but also for social services, where our patients could go to areas within La Maestra or outside of La Maestra to see if they qualify for any kind of insurance or coverage that would allow them to get access to more healthcare. Now we're going to talk about what is my favorite part, which is quality of care. How have we leveraged technology to increase quality care. And I have to give a big shout out to Sal, our CIO. We put together a team that we call the SSRS team. And it's a multifunctional team with different expertise within it. Quality improvement people, EHR, IT, and clinical staff. And we were able to get areas from our EHR that were already there and kind of organize them in one particular place, which is our quality dashboard. This is something that is homemade, La Maestra, and has allowed our providers to be able to address quality care for our patients. So once they click in that link that you guys saw before, this is what it pops into the provider's view. The provider is able to click in any of those areas that you guys can see in color. What it means, the red color is that the patient needs this to be addressed. If it's in green, means that the patient had already addressed it. And if it's in yellow, means that the patient, maybe something was ordered, but the results hadn't come back. So the patient is able to, if the patient is able to talk to the provider can see, okay, I can address this, I have time, or I don't have time to do this, and is able to either schedule an appointment for the patient to come back or talk to the care team to see what we can do for that particular patient at that moment. And more quality for us, so this is what we have been able to do. So I was able to extract some data from 2014, 15, 16, and 17. And this is what we have been able to see at La Maestra. We have increased compliance from 2014 to 2017 in diabetes control, hypertension control, cervical cancer screening, colorectal cancer screening, and depression screening. All these, as you guys remember, we implemented EHR. We started the implementation in 2012. The full implementation was not completed until 2013. And this is what we have seen through the years from 2014 to 2017. And we're hoping that with the technology, the way that it's moving, this is going to be something that we're going to be able to see even more improvement. Now, something else that we do is reporting. As Leah had mentioned, UDS is something that we have to report as federal qualified health centers in every single year. Our UDS in 2013 was being reported as a sample chart, only 70 charts. In 2014, we leveraged technology and we decided to move to a full universe. This is exactly the same metric that we have to report. As you guys can see, 458 different charts were reporting. In 2017, they decided to change the game on us a little bit, and they reworded or they changed the metric to 2 years, not 3 years of age. And it was easier having the technology available in the EHR to be able to report that particular metric without having to do that much manual work. We're able to get this information, talk to the providers, and implement what we need to implement in order to provide quality care. Now, there was a price that had been paid, and it's important that we mention it. There is definitely more ancillary staff, and I can hear my CFO saying, yes, we do have a lot of ancillary staff. Definitely, there was a reduction of productivity, more demand for reporting since now we have the technology available, and finally, provider burnt out staff. So with that being said, how did we address, what were the best practices that we implemented in this case? For more ancillary staff, what we did was we have been able to use that ancillary staff and engagement of the different stakeholders, able to influence the better utilization of the EHR system and project what we have and project exactly what the EHR can do. We have been able to increase the competency of the stakeholders. So what we have done with our SSRS team was to do this particular part. So we were able to explain what technology can do. Utilization of standing orders to allow staff to work from the top of their licenses, MAs, scribes, LVNs, nurses. The adoption of the care team standard has allowed the utilization of the extra staff for the benefit of the patient care. And lastly, the reduction of productivity and prevention of burnout staff, we have been able to adopt the care team approach that has allowed providers to be able to work more effectively. Co-visits. This is something that I think we should, and other health centers should leverage. Co-visits, where the visits usually started by the nurses and ended by the provider. That has allowed the provider to have more time with the patient when the nurses or the MAs has been able to address the first part of the visit. And that has increased the productivity, and that has also increased the quality of care. Something else that is very important is how has the provider been able to participate in the huddles. That way the provider has a realistic expectation of what their day is going to be. Increasing of the efficiency and uses of EHR so that the clinician can spend more time interacting with patients. We have established a schedule team. One team that look at the skeleton of the schedule, and one team that scrubs the schedule in order for us to be able to increase access to care and to create right expectations for the providers. And more demand for reporting is a little bit more time consuming, but we have formed our SSRS team, which is a multidisciplinary team that allows the reporting to be more efficient. The SSRS team has adjusted the EHR workflow to allow quality of care and at the same time proper reporting. Thank you very much. This is the presentation that we have.
Thank you, Sonia, for your wonderful presentation. Thank you, Saul. And well, I would like to thank you, Leah, Sonia, and Sal for these wonderful presentations. We're going to start the Q&A session. If you have any questions, please submit your questions through the question box on your control panel, or use the hand raise icon and your line will be unmuted. All right, we have few questions on whether the slides are going to be available. The answer is yes. After the webinar is over, we are going to send the slides to all webinar participants, or you can also visit our website, www.nchph.org, where you can find the presentation and the recording of this webinar. The website is nchph.org. That is November Charlie Hotel Papa Hotel Oscar Romeo Golf. And we have a question. So this is for Leah. This is, I believe, about the study methodology. The question is, how many health centers participated in the study, and how long did the study last? And what was the study methodology? I believe these are three questions.
So that's a great question. It was all of these, the one kind of dilemma a little bit with the HRSA funding, it's great funding to have, but the turnaround time is pretty short. So this was actually only a 1-year study. And we aimed, rather than just talking to one person per health center, at a lot of health centers, we aimed to get multiple perspectives on the same processes within health centers. So we ended up with, I think it is in one of the slides, we had 6 different health centers, 17 different informants across those 6 health centers. If we'd had more time, I actually had a baby right at the end of the study too, where I would have been happy to continue it a little bit longer, just to get a few more perspectives because of some of those limitations that I mentioned. But we had a semi-structured interview guide that we used for each of the participants, and then we used a qualitative analysis software to extract the themes. So we did try to do it even within that tight window, because that's both for conducting and reporting the study. Within that tight window, we tried to do it as rigorously as we could.
Excellent, thank you, Leah. And I believe this is another question for you, Leah. It says, what were the challenges that were more frequently mentioned in the study?
Can you repeat that one more time?
Yes, it says, what were the challenges that were the most frequently mentioned?
Sure. I actually think the whole issue around reporting, I think, was something that we only somewhat had on our radar when we started the study. And then, so using EHRs for UDS reporting, for meaningful use reporting, sometimes other layers of reporting as well. I think that was something that we hadn't really anticipated. And then people talked about it so much in some of our early interviews that we started asking everyone about it. And that seemed like a real challenge, just such a different way of having to think about where your data had to be, especially from a paper record, where as long as you write it down, someone can read it. Even sort of shifting that for, typing into a certain box, but then knowing that if, basically if you didn't put it in a very specific, in the information in a very specific place, for the reporting purpose, it's like it never happened. And I think people found that really, they understood why, I think, but they also found that just kind of raised the stakes so much for everything that they were doing, and sometimes would be hard to catch until later. So I think that was one of the big issues. And then I think I was happy to hear that, Sonia, actually, that at La Maestra, that you're finding ways to communicate with outside providers. I think that's been a real continuing dilemma. I know that even I worked on another study that was more looking at accountable care arrangements in the safety net, and so with different types of providers, and even for them, even with some really sophisticated systems, sometimes figuring out where information needs to live, both for communication and for all the documentation that would go along with that, is also still a real challenge.
Great, thank you, Leah. There are two questions for La Maestra. The first question is, how does your EHR stratify patients by risk? Does it have a built-in registry feature or other feature to allow you to easily assessing patients to a risk category? Ours doesn't, and I think this is a problem in many systems.
Yeah, so so what we have done is we haven't stratified all the patients, but definitely the ones that with chronic conditions. So we have worked with our CMO. We're chosen the patients and what demographic information we find that are important, or our providers find that are important, and we have created our own algorithms, and then we are able, each EHR is different, so they will have to work with the EHR vendor to see if that would be possible. And then once you choose the algorithm, so you are able to give number or stratification depending on the chronic conditions and the demographics information that you can have.
All right. Thank you. And there is another question. Could you please describe the scheduling teams you use at La Maestra?
Absolutely. And I'm glad, because I know my COO is listening to me, and also the scheduling team. So the way that we do it, on the scheduling team, we meet once a week, twice a month sometimes, and we look at the skeletons that we have put together for the providers, depending on their productivity, their what kind of patients they see, and if they're MDs or if they're mid-level. Then we look at the patients that are empaneled to them, and we look at the complexity of each, the empanelment of their patients. And so we make sure that the patients that are being scheduled for 15 minutes or 30 minutes, it makes sense. And we talk to the providers, and we kind of get their feedback to see if they are, if they're happy or what would they do different. So we also take in consideration the providers' feedback to be able to accommodate their skeleton of the schedule. And then we have a second part of the team, which is a clinical staff, and people that work in the call center and work on the floor that scrub the provider schedule in a weekly and daily basis, and make sure that the patient that is coming on that particular day or that particular week, if they're coming for a follow-up, that they have everything ready. And if the patient has 2 or 3 appointments that were made and one wasn't canceled, so we cancel the appointment so that we increase the access to care for the other patients as well. So there are two different components. One that we look, one is executive management, and the other one is down in the floor in the call center.
Excellent. Thank you, Sonia. And I do not see any additional questions. However, if anybody else has any questions, you can send me your question. My email address is jose.leon@namgt.com, and I will make sure that the presenters receive the questions so you can get an answer. Well, thank you so much. It's 2:02 p.m. Eastern Time. If you have time, please visit our website. You can find information on upcoming webinars, publications, and information about our national conference. Our website is www.nchph.org. You can also join our mailing list and receive HRSA updates, Medicare and Medicaid updates, funding opportunity announcements, and information on senior programs and other resources and services. You can also join our social media. You can follow us on Twitter and subscribe to our YouTube channel. And you can contact any of our staff members, and we are going to get back to you as soon as we can. I would like to thank one more time Leah, Sonia, and Sal for their wonderful presentations. And to all our attendees, please complete the post-survey. Your information and your responses helps NCHPH to improve our webinars. If you have any training and technical assistance needs, please contact any of our staff members. And once again, thank you very much for attending this webinar. And thank you to our speakers. Thank you and have a great afternoon.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks. Bye-bye.